Welcome everyone to the Minnesota Public Health Association's Oral Health webinar. I'm Mary Grand. I use she, her pronouns, and I'm MPHA's Executive Director. And we are so excited to have a series of oral health and public health webinars for you this year. And so today we will be talking about oral health and population health, more than a pretty smile. And we have just a couple of housekeeping rules that we're going to go over. These are standard Zoom reminders. Feel free to mute your microphone, and you can put comments in the chat at any time. And you can have your camera on or off. And we always have our MPHA Ancestral Land Statement, which was developed by our Health Equity Committee. And I'll add that our Health Equity Committee is working on additional actions to take as well as the statement. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a longstanding history to the land since time and connection to the land since time immemorial, and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and US governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. And now I have the great pleasure of introducing our speakers today, and I'll let them introduce themselves, but I'd like to turn it over to Dr. Lubov Slashova, and she's going to introduce herself and the panelists. So thank you.
Thank you, Mary. And I'll introduce each of our panelists as right before they present. But we have John O'Malley and Dr. Mike John today. And I'll be moderating some of our discussion and question answer time after their presentations. And I'll just briefly introduce myself. I'm research director and work as a dentist for Apple Tree Dental. Some of you may not be strangers to the nonprofit organization that has 9 centers throughout the state. And so my background is in geriatrics and special needs as a clinician. And I also have specialty training in dental public health and am a diplomate with that specialty. So today we're going to be discussing approaches to dental measurement and trying to fill the gaps in knowledge through measuring patient-reported outcomes, such as the oral health impact, and optimizing our approaches of disease detection or identification monitoring. And 2 of our panelists will present 2 different approaches for that. But I encourage you in the chat, if you want to introduce yourself or tell us which organization you're representing. If you have an oral health measurement tool that you know about or have utilized, if you just want to pop that in, it might be interesting for us to include in our discussion and just good for reference for our presenters. So I will stop sharing and ask that John O'Malley share his screen, and I will introduce him while he pulls up his slides. John O'Malley is the lead biostatistician at CareQuest Institute for Oral Health, where he focuses on periodontal disease, phenotyping research as part of his PhD dissertation at the University of Michigan's program in health infrastructures and learning systems and scientific computing. Very long title to that department and program. John served 2 tours in the U.S. Peace Corps before beginning a 10+ year in dental public health. And we at Apple Tree have been fortunate to collaborate with John on some research, including part of his PhD dissertation work. So thanks so much for joining, John, and look forward to hearing your insights.
All right. Thanks for the intro there, Lubov. Hello, everyone. I'm John O'Malley. Thanks for that introduction. We're talking about periodontal disease a bit today. So I'm representing both CareQuest Institute for Oral Health for a biostatistician, and also my dissertation work as part of my degree, that long title degree at University of Michigan. So we'll talk a little bit about periodontal disease. Keeping in mind, I am not a dentist. I'm talking as a data guy who spends his days crunching numbers. So you're always going to get a more detailed perspective, I think, from having periodontists and dentists on the call. But just from a very high level perspective, let's just cover what periodontal disease is. I think people are familiar with gingivitis or inflammation of the gums, and then periodontitis would be a more severe form where you actually have some destruction of the tissue that surrounds the tooth. So what I'm particularly interested in is how we're going to measure periodontitis. And if you might have seen out there prevalence measures of periodontitis. If you're looking at like CDC measures, you're going to be seeing things like mild periodontitis, moderate, severe, anything that's a result of the NHANES surveys. That's how they're putting out their classifications. They're putting out prevalence measures based on mild, moderate, or severe. So that's population health is often measured. And then in 2018, it was a revision to how clinicians are suggested to diagnose and classify periodontitis based on the American Association of Periodontology and the European Federation of Periodontologists. They kind of broke it into two axes. There's the extent of the destruction around the tooth into stage 1, 2, 3, or 4. And then there's a grade, which is kind of like how fast is it moving? Is it been slowed, or is it moving aggressively? So these are kind of the ways out there that the community is classifying periodontal disease. So we try to keep this in mind when you're someone like me who's trying to measure this out in the field. And the primary way that dentists are going to classify the disease when you're in someone's mouth is by using a probe. People have ever been to the dentist and had the dental team calling out numbers that they're poking around your tooth. They're taking a perio chart, and they're using a probe to measure millimeters of bone loss or clinical attachment loss by going around the tooth. And this is just a depiction of how that kind of works using the CDC classification. So the primary way we're measuring periodontal disease right now is by measuring these pockets around the tooth. So why am I so focused on measuring periodontal disease, and why this is so important? It's because if we knew the periodontal status of our patients in the clinic, or even at a higher level, imagine if like clinics could aggregate their data through health information exchange, and we could pull population level measures out of exchanges. You could start to learn things like, well, what % of our patients have different levels of periodontal disease? Right now, if you went to an office and asked that question of their patients, that would be very difficult to measure for the reasons that we're about to get into. But not only what status is the disease, but how has that trajectory at a person or population level changed over time? It'd be great to know what their status is so we could figure that out. And then are people getting the services that they need? Are people who have periodontitis getting the recommended frequency of periodontal maintenance after an initial procedure called scaling and root planing? In order to measure things like that, you have to know who has periodontal disease from the beginning. And then if you're like me, you're particularly interested in like big picture research questions, like does treating periodontal disease result in any cost savings in diabetes care? Surprisingly difficult to answer that given the data sets that are out there. So I'll talk a little bit about my research in a bit, but I think these are an example of the types of questions we would love to be able to answer, but to do that, we have to be able to measure it in the first place. So I'm going to talk a little bit about the challenges around this, why this is such a hard thing to measure. If the dental industry was similar to how medicine worked, anytime someone in the dental office tried to submit a claim for reimbursement from a dental insurance company, you would try to get reimbursement for your dental procedure by writing down a CDT code. CDT codes are the procedure codes for dentistry. And if it was like medicine, you would add a ICD-10 code to that, which would be the diagnosis code to kind of explain the reasoning for why the procedure was needed. And that's how a lot of medical claims work. You have a procedure and a diagnosis paired together. And from that, you can kind of see, oh, they did this for this reason. If dentistry was like that, you would see claims like this. These are just examples. Someone might receive an ICD-10 code of K05.311, which is chronic periodontitis localized, moderate classification, and that might be paired with a CDT procedure code like D4341, which is scaling and root planing. So the reason for the scaling and root planing would be because of that periodontitis diagnosis. One other example might be someone gets a K05.22 code, which is for aggressive periodontitis, generalized, severe, and that might be attached to a procedure code like D4910, which is for periodontal maintenance. So the reason that they're getting the periodontal maintenance is because of this diagnosis code here. And if things were paired up like that, it would be pretty easy for someone like me to be able to query dental records and pull out those ICD-10 codes and be able to say something like, oh, looks like X% of these people have a code that is periodontitis. Or like the two challenges with what I just described is one, these ICD-10 code classifications don't align with the slide from a few slides ago, the CDC classifications, which were mild, moderate, severe, or the AAP, EFP classifications into stage and grade. So like ICD-10 doesn't really align with how clinicians are doing this in daily practice or recommend to do it. But then the much bigger issue here is these codes aren't really being used to begin with. It's not very common in regular practice for the dental teams to be recording these diagnosis codes. I would say primarily because the dental insurance companies are not requiring them on a claim. So the codes oftentimes aren't even there for me to query, even if I wanted to. So in the absence of having a lot of these diagnosis codes in the record, how are we going to figure out who has periodontal disease is kind of a question I'm trying to answer. Dr. Slasheva and I and Appletree have been research partners for a couple of years now, trying to help answer this question. This is a lot of what my PhD dissertation is all about. We're trying to combine different sources of information within the clinical record together to try to abstract what we think is going on. This is a process called computable phenotyping, which is a really fancy sounding way of just saying classifying people. We're not diagnosing officially. We're not giving someone a diagnosis of a disease. We're just, to the best degree that we can, trying to electronically and algorithmically compute who most likely has the disease. So we're kind of approaching 4 different ways of doing that. We're trying to look at chart notes. Chart notes are when the dental team is writing in free text what they're observing in the mouth. So that's such as writing sentences or paragraphs, phrases in the electronic dental record, which is kind of a difficult thing to write an algorithm to extract. So that involves a process called natural language processing, kind of asking the computer to extract the meaning out of text. The second one there is the probing chart. That's where they're poking around your mouth and calling out the millimeters of loss around a tooth. If you know all the amount of bone loss around all the sites of all the teeth in a mouth, you can build an algorithm to extract from that what we think the different stages of periodontal disease are. It's a bit complex to do, but it's possible to pull it out from that. The other one is diagnosis codes. I just said in the last slide that we're not using diagnosis codes in practice very often, but sometimes you find a partner who is, and Appletree has been using a custom set of diagnosis codes for decades now, and that's their data set, which makes it great. They're just a great team to partner with because we have that extra level of detail. And then something new we're trying together is the assistance of artificial intelligence in running over the x-rays that patients have. And the computer is able to automatically calculate the amount of bone loss around teeth. And what we're working on and researching now is, can we use that information to add into everything else that we know about a person to try to figure out what their level of periodontal disease is. So if you, so our task is kind of looking through all these sources, finding out which ones are working and how well and how accurate they are, and finding a way to put them together. A challenge is that any one of them by themselves is going to be inadequate. I'm just copy pasting an image out of research conducted by Jay Patel and his team with research out of Temple University. Jay Patel is like the leader in periodontal disease phenotyping research out there, and is on my dissertation committee, and has been really helpful in providing guidance. What you're seeing is an image of an exercise he did with his data out at Temple, which found that if you're only relying on the periodontal disease like notes, that the free text that the team is writing into it, only 36% of the people who actually have periodontal disease are going to have a note that reflects that they have periodontal disease. And Temple is using diagnosis codes somewhat, but they're finding that only 18% of the people with periodontal disease actually have a diagnosis code that says so. 80% of the people with the disease have periodontal charting, which he presents a lot, but it's still not 100%. So what his team has been working on is trying to figure out combining those sources of information together in one algorithm that's going to generate who most likely has it. So compared to this research where Dr. Slasheva and I and Appletree are trying to add another layer to this, which is that AI reading of the radiographs. And so we're hoping that by combining all those, that we can get a pretty good sense of who has periodontal disease, to what extent they have periodontal disease, and then we can calculate prevalence and care, disease trajectory, and compliance with guidelines, and do some interesting research and all of that. So this is where we're headed. Just to say, for if anyone is going to be in New Orleans for the IADR conference in a couple of weeks, Lubov, myself, and Jay Patel will be presenting a poster on this, on where we're going and some of the stats that go along with it, and a lot more to come as I work on this as part of my dissertation. So if you have any questions, happy to talk periodontal disease phenotyping anytime.
Thanks, John. And I encourage you to put your questions in the chat or jot them down. We'll move directly to our next presenter, Dr. Mike John, and I invite him to pull up his slides as I introduce him. So Dr. Mike John is a clinician researcher trained in dental prosthodontics, oral facial pain, and epidemiology. He's an associate professor for the University of Minnesota's School of Dentistry and School of Public Health. Dr. John serves as editor for numerous peer-reviewed journals and leads a diverse research team that investigates the use of dental patient-reported outcome measures. Welcome, Dr. John, and we look forward to your presentation.
Yeah, thank you, Luba. Good afternoon. You heard from the previous speaker, John, that, yeah, we have some issues with measuring one of the central diseases in dentistry, periodontitis, and I can tell you we have the same issues with measuring the second major disease in oral health, caries. But we have also some good news for you. And here we can actually measure the impact of caries on periodontitis and all the other oral diseases on the patient. And before I continue, research that is reported in this presentation was supported by the National Institute of Dental and Craniofacial Research under these two award numbers. The central concept in dentistry and in oral health is the concept of oral health impact. And we have many oral diseases, but the two major oral diseases, and John talked about periodontitis, you see this on the left side, an infectious disease, and caries actually dominate oral health. They dominate oral health also through their consequence, tooth loss. And when these oral diseases affect an individual, then the individual becomes affected, and we have pain, we have functional problems, patients are not able to chew, for example. So basically, we have a suffering patient, and this suffering, I call this in this presentation, oral health impact. So we are talking about how oral diseases impact daily lives of patients. And the concept of oral health impact is key to many important concepts in dentistry. So it is key to the concept evidence-based dentistry. We certainly want to apply to patients the best treatments to reduce oral health impact. Ideally, we even want to prevent oral health impact from occurring by applying the most effective preventive strategies. The concept value-based oral health care is an extension of evidence-based dentistry when we take cost into account. Of course, when we apply interventions, they come with a cost, and we would like to have the best intervention in terms of outcomes if we hold the cost constant, or if we have two interventions with similar outcomes, of course, we would like to have the cheaper intervention applied. Dentistry has also a lot of buzzwords, for example, access to dental care. And this discussion about access is only helpful if we take the concept of all health impact into account. Of course, we want that we have access to all healthcare that reduces, eliminates all health impact. Just access to something, of course, is not useful. The same is true for equity, where I find that many discussions about equity of all health are kind of superficial, because we are talking about equity of all health impact. And without measuring all health impact, the discussion about equity is kind of non-informative. And there are many other concepts that rely on all health impact. For example, workforce planning is another topic where certainly we need a workforce to apply or to address all health impact. So we often hear that people want to move the needle in clinical oral health or in dental public health. And the needle actually is moving the concept or health impact. And of course, if you want to move the needle, you need to have an instrument which actually would be the needle that you move. And in the remainder of the presentation, I will show you what is behind the concept all health impact. And I will introduce also a practical measurement tool that can be applied to actually score all health impact and then, of course, through intervention, reduce it. It is useful to consider all health as a coin. And because I'm originally from Germany, I have picked here a euro as a coin. And you see on the left side, these are the oral conditions that a dentist, a professional, would see. And I counted actually the number of oral diseases. We have 1,323 oral conditions. So we have a large number of oral conditions. And these oral conditions affect patients in a very heterogeneous way. And here on the right side, you see all the problems that can be caused by all disease. And then, of course, this is only a sample because the space of all health problems is infinite. And while 1,323 is certainly a big number, and we would have problems to measure all these conditions, it is certainly a larger or an even larger challenge to measure an infinite number of all health problems, because how can you actually measure something that is infinite? It turns out that all the oral health problems actually fall into 4 categories. And it turns out that they fall actually only into 4 categories. So basically, orofacial pain, orofacial appearance, oral functions, and the psychosocial impact due to all disorders are the necessary and the sufficient elements of oral health impact. And because of their importance for oral health, they are also called dimensions of oral health-related quality of life. And I will give you a little bit an example why pain, appearance, function, and psychosocial impact are the core dimensions. So think about of a bike accident. And in that bike accident, one of the upper teeth, frontal teeth, is lost. And so immediately you have a painful impact in that area. Certainly, if you would try to bite something, there would be an impact. You would have problems. when you open your mouth, you would certainly see that there is an impact on the orofacial appearance. And you certainly have also a psychosocial impact. For example, if you are someone like me who teaches to dental students, I would certainly avoid going with a gap between my teeth to my dental students because I would be embarrassed with that situation and would first go to a dentist for provisional restoration. So you see here with a bike accident, we have a painful aesthetical, functional, and psychosocial impact. And the same is true for a caries impact, or if you have, for example, a TM joint disease. There's a lot of science behind the dimensions of oral health-related quality of life. We first performed an exploratory step using an exploratory factor analysis. This step generated the hypothesis that oral health has these 4 components. There's another version of factor analysis called confirmatory factor analysis, where you can put this hypothesis to a test. And we did this with another sample of international dental patients and general population subjects. And we could confirm in this investigation the existence of the 4 dimensions. We did another validation step with close to 10,000 subjects where we had hypotheses how these dimensions explore their effects on patients, and we confirmed this. We had another generalizability step where we expanded the use for other questionnaires. And then we had a really large study with close to 16,000 international patients. And I show you a little bit these results because they provide a little bit of global perspective for these dimensions of oral health-related quality of life. And so we studied 32 countries in all WHO regions. And if the theory of the 4 dimensions is correct, then impaired function and appearance, pain, and the psychosocial impact of all diseases would be the reasons why patients seek treatment worldwide. And therefore, we asked dentists in these countries to check their last 10 patients for the primary reason why these patients sought care from them. And we explained to our dentists that we were interested in patients' oral health problems, but we did not tell them specifically that we wanted to test the oral health-related quality of life dimensions. And therefore, we offered as reasons for treatment seeking the 4 dimensions: pain, function, appearance, and psychosocial impact. But we offered also a 5th category, other reasons. And if the 4-dimensional model of oral health impact would be correct, then we expected that the majority of the patients would be in the 4 categories of function, pain, appearance, and psychosocial impact as the reasons for their treatment. And this is actually what we observed. Overall, as it is plausible, pain is the most important reason globally, followed by function, appearance, and psychosocial impact, why patients seek care. The prevalence of other problems was about 5%, and if that is of interest for you, I can explain that a little bit in the discussion, what other problems were mentioned by the dentist. Overall, these results are very plausible. So in the middle, you see dental fields or dental disciplines, and you can certainly see that in the field of orthodontics, patients seek mainly care for aesthetical reasons, which is very plausible. Now, all medicine, TMD, temporomandibular disorders, or facial pain providers naturally see more patients with pain in the oral area. It is certainly also plausible that African countries patients in these countries have more pain than, let's say, European countries. So overall, we have a very plausible picture for these 4 dimensions and the reasons why patients seek care for them. And here we have this very practical tool called Oral Health Impact Profile for measuring these dimensions. And you see here that we have 5 items. We have very plausible questions such as, yeah, do you have difficulty chewing? The reference period here is last month, but we have also shorter reference periods for clinical use, for example, 1 week. We have also for population use longer reference periods such as 12 months. And you see that the patients are asked about their problems and responses are collected on a frequency scale from never to very often. And you see here the actual 5 questions. Chewing is certainly an indicator for oral function. There is pain, then there's the appearance, then there's another question about function. And the last question is about the broader impact of oral disorders. The Centers for Medicare and Medicaid Services, I see here a typo, will introduce OIP5 measurement this year in the Medicare Current Beneficiary Survey. So we will have a comprehensive characterization of oral health now in this survey. Large surveys, for example, the All of Us study with 1 million participants will use the OIP5. And we have also talked with our colleagues from the Minnesota Department of Health that OIP5 will be introduced in next year's BIRFES study. So many oral health settings, many non-oral health settings will use the OIP5. And OIP5 actually is quite a very practical tool for medical dental integration. And OIP5 can be used in, or is used in many dental settings, but it can also be used in many non-dental settings because it takes less than 2 minutes to fill in the information. So let's talk about a setting of a primary care physician's office. Or another setting would be a nursing home community. In both settings, an OIP5 could be given to participants or to patients. Let's say in the primary care physician's office, the OIP5 would be given to patients in the waiting room. And then the patient takes the questionnaire and gives it to the physician. And the physician could just look at the piece of paper and could see quickly whether there is an oral health impact or whether there is no oral health impact. Of course, if no oral health impact exists, the physician could briefly comment on that finding and then could continue with other medical assessments. If an oral health impact exists, the physician could give the patient a phone number where the patient can get oral health advice. Another option would be, for example, teledentistry, where a trained oral health professional could get in contact with the individual regarding the oral health impact. The point that I'm making here is that oral health impact screening with an OIP5 should definitely be followed up by an intervention, that we do something for the patient, but that does not necessarily mean that each patient needs to be sent to the dentist or to the specialist. We have very pragmatic, very effective options like a helpline, like a teledentistry option that could certainly take care of problems in larger populations. So I hope I could give you some introduction into practical oral health impact measurement. And if you want to move the needle in oral health, and of course, we would encourage all the dental and all our non-dental colleagues to do this, oral health impact is the concept you should target, and OHIP5 is the tool that you can use. And of course, there is no copyright for this instrument. It is in the public domain. Thank you very much for your interest.
Thank you, Dr. John. I will present just a few more slides here before we jump into our discussion and question and answer. But if you want to jot down your questions for Dr. John or John O'Malley in the chat as we move into that discussion portion, feel free. So many of us are coming from kind of the grassroots, or potentially, I think, a couple people from health plans, insurance companies. And so you're kind of thinking about the implementation side of things. I know as good researchers, our panelists have identified the gaps that exist, and they're developing some instruments and techniques to fill those gaps in oral health measurement. But some of us are probably thinking, well, how does this apply into our work settings and our work? So I will just provide you with a brief introduction to Appletree Dental, the nonprofit I represent and work for, and discuss how we're trying to implement actually both approaches that have been discussed today. Appletree's been around for almost 40 years, and our mission is to overcome barriers to oral health by partnering with communities and diverse interprofessional disciplines to foster healthy communities. There are 9 centers throughout the state of Minnesota, represented by the red circles, and we partner with about 150 community sites through our mobile dental program to serve low-income children, adults with disabilities, and older adults in long-term care settings. And you can see the green shaded counties around each of the red circles that represents patients who are coming either to our centers or served through our mobile programs. And over the course of the past 2 years, we've seen patients from all counties in Minnesota due to just being an access point for a lot of publicly insured patients, but also that we have specialty expertise, including pediatric dentists, nurse anesthetists, a sedation program, and accessibility features such as ceiling lifts and just can-do approach to making oral health care services accessible to all patients, regardless of ability or age or income. Our care delivery system is called Community Collaborative Practice, and that means we deliver oral health services where people are living, go to school, or receive other health or social services. And as you can imagine, that means that our practice is interprofessional. It's out in the community. It doesn't necessarily wait for patients to come to the dental office. It's more proactive. And we collaborate with our community partners, whether it's a nursing home or a Head Start program or a school, to understand how are those professionals already engaging that population. What are some of the best practices of working with those populations that we as oral health professionals can learn from to overcome some of those barriers to oral health that population experiences. And in collaborating across professions in that way, delivering our care on site many times, that really does integrate oral health care into overall health homes. As a clinical provider organization, we are supported through our innovations teams, of which there are 6, and research is one of those. And that really helps us to work on internal quality improvement projects and support and sustain the access sustainably that we offer as a nonprofit. And it helps us function as a learning health system. We've adapted the concept that's becoming more and more common among hospital systems and health administration. John O'Malley can give you he's taken whole classes on each component of the learning health system, so he can correct anything I'm saying incorrectly here. But Appletree has adapted that concept to center our community collaborative practice model in the center there. And if we go to that purple delivery system arrow first, we've collaborated with our community partners to develop a model of care that suits the particular population that has traditionally had barriers to oral health. And included in building those models is an infrastructure to capture in a structured and uniform manner the care that we're delivering, including what John O'Malley mentioned as our custom diagnosis set of codes that track the recommended treatment and the reason why that treatment is recommended as a primary finding. Early on when, 40 years ago when the organization was started primarily to focus on providing care to older adults in long-term care settings, there was a need to communicate those primary findings to guardians and responsible parties to, communicate the recommended treatment and obtain consent. And since then, it's evolved and expanded. But that delivery system gives us the working knowledge and the data that we can learn from through research, both internally with our partners, such as CareQuest, and academic partners, and also learning from the external knowledge that's coming through publications, collaborating with folks like Dr. John on learning about new tools and measures that we might implement. And that really feeds into things that we need to implement into practice, different innovations. Our clinical innovations team and education teams, they work with the research team to implement and then reevaluate how those novel approaches impact our delivery system. So I will turn it back over to our panelists here. They've discussed some approaches to filling the gaps in measure that exist in oral health, but I'm curious to hear from both of you. How do you envision, if everyone was using the measures that you're discussing or the approaches you're discussing, what kind of impact would we have within the oral health profession, but also in our efforts to move towards belonging back in the mouth, that medical dental integration piece? What does the world look like if your approaches and measures were implemented widely?
Ooh, I guess I'll go first there. I think there's a micro and a macro scale, I think, to like kind of the methods that I'm describing. So at a patient level, we'd be able to like a lot better understand who's getting care, who needs it, how well is the system functioning for people. And then in a macro level, you can imagine aggregating a lot of this information up through maybe health information exchange. So you could do some like surveillance. Like no one really knows in Minnesota, like what % of adults have periodontal disease. There's actually like the CDC doesn't have a survey that could do that. There's a national survey, but it doesn't have a sample size for Minnesota. And so you can maybe ask people that in a survey, like on a phone, but how would they really know what the status is of their own mouth very well? And so I'm trying to get to that macro scale eventually so we can do much better understanding of like the oral health of our communities. And the medical dental integration, I think, is like a whole separate piece, but that is a lot of what I would like to study, and I'm really, really interested in. Like, does treating periodontal disease have any impact on other things like diabetes or cardiovascular disease or all that? And just to know that, you have to be able to link the two in a data set. You have to know who has periodontal disease. You have to know who has diabetes. You have to know when someone is treated for one or the other. And I think, as I was explaining, hopefully in that slideshow, at the moment, we're just not set up to answer that question. And of course, Lubov knows where my PhD is headed. So we're trying to pilot that sort of exercise with data from AppleTree. And hopefully at the end of this, we'll be able to show like how this could be useful and encourage other people to follow this path.
John, before we move on to Dr. Mike John, some of our participants here might be familiar with a lot of the studies that are linking conditions like periodontal disease, which is an inflammatory condition in the mouth, to cardiometabolic conditions, and maybe even further the cost of care to programs like Medicare or the hospital systems. And the key difference in the approach you're taking and the approach that was taken in those studies is that treatment of periodontal therapy was used in those studies. Is that correct? I don't know if you want to speak to.
Sure. So a lot of those studies you're talking about were based on insurance claims. And so you could see who received treatment and who was like, how was there money exchanged in return for that treatment. But the insurance claims don't have the diagnoses built in because of those. It's just not common practice in the industry. So there's just a lot of limitations if you're going to use insurance claims analysis to try to figure out if there's any impact of treatment on the diabetes side of things. And so I'm trying to go in through a different door using the clinical notes instead, where you can actually see who has disease and if that changes. And I think that will be like the big improvement over the way it's traditionally been studied.
Thanks. And Dr. Mike John, what would the world look like if OHIP-5 were used widely in the oral health profession and potentially beyond?
Yeah, I think the industry has a unique chance where, in my opinion, our medical colleagues are, it's difficult to go for them. But the industry is small enough and big enough for, I think, a common language of oral health impact. So when patients come to the dentist, we want to know what their oral health impact is. We want to explain to them what treatments they receive and how their oral health impact can be lowered. Patients would be interested in something like a prognosis that, oh, within 2 days, within 2 months, you will, or the oral health impact will be reduced by 50%, 60%, any quantitative measure, so that patients know what treatments actually can do for them. We want to know what the population health impact is, because we want to have population programs. The general population, in a sense, can be understood as the mother of all patient populations, where certainly when an oral health impact on oral disease hits the patient, they on individual in the general population, then they become patients. Dental health professionals treat these patients and send them back to the general population. So it's a cycle between being an individual in the general population and then sometimes becoming a dental patient. And certainly, if we would be on the same metric, it would be helpful for our communication. And of course, researchers need to express treatment effects in the metric of oral health impact, because that is what patients are interested in. This is what dentists are interested to deliver. So in my world, everybody would speak OHIP-5. And everybody would have standardized settings, and we would be all on the same metric. And that would be, I think, a better world for our patients and our community subjects.
Thank you. Now I want to open up to our participants to see if you have a comment about the way that you've experienced oral health measures, or if you have a question for either of our panelists. Please unmute and speak up, or put your question in the chat. Don't want to interrupt. Feel free to raise your hand if you want to get in queue. But just, Dr. John, I wanted to follow up. You said that the questionnaire was available in the public domain. Where can people gain access to that? And just a follow-up question, which method of OHIP administration is most reliable? Patient filling it out themselves, a phone call, which administration method?
OHIP-5 responses are pretty robust against methodological influences. So you can ask a patient actually about difficulty chewing in a personal interview. And many health professionals do this. And let's say if we would be in a non-dental setting, let's say in a nursing home community, certainly these questions could be asked directly to nursing home inhabitants. And so personal interview is possible. Certainly giving a patient a questionnaire or an individual in the general population would be also an option. And according to our results, there are no major differences in terms of the magnitude of the scores. And of course, then there are all these other advanced technological tools to collect responses, web-based data collection and app-based data collection. That's also possible. This is certainly an advantage that oral health impact can be measured also remotely by assessing patients' impact via an app, via web, but also maybe with a phone. So the administration methods for the OHIP-5 are pretty interchangeable at this moment, and scores received with one method would be compatible with scores achieved with another method.
And where can people find the questionnaire if they're ready to run with it?
Yes, at this moment, it is a little bit cumbersome. Please send me an email and I will respond as quickly as possible. In the future, we would like to have something like a web page where people can just download the instrument. Certainly, some versions are already available in the internet, so a Google search would also bring you to the OHIP5 tool, but of course, I would be happy to send you our questionnaire that we use in our clinic if you would be interested to have the OHIP5 questionnaire.
Thank you. There's two questions from two individuals in regards to OHIP5 questionnaires being utilized on minors or being adapted for use in children. Could you speak to that?
Measuring oral health impact across the entire lifespan is, of course, the ultimate goal. And the concepts are actually equally important, whether you are 90 or whether you are 9. Because when we are talking about the oral health dimensions, it is relatively clear that the jaw system has a job to do. And we call this oral function. And what is this? We want to talk, we want to speak, which is similar, eat, bite, swallow, all these things. So this is oral function. And of course, we don't want to be bothered by pain and discomfort. That's the second dimension. We want to have a socially acceptable appearance. That's the dimension orofacial appearance. And then we don't want to have a broader influence on our health and well-being. That's the psychosocial impact. OHIP5 was developed for adults, but researchers and practitioners saw quickly that there is basically no difference between a 19-year-old, where OHIP5 would, strictly speaking, applicable, and a 16-year-old. And so researchers and practitioners used OHIP5 for adolescents. And it's likely a very safe use if you have an adolescent giving this individual or group of individuals the OHIP5 would probably be a safe way to do. We have recently developed an OHIP school. So we are trying actually to get to children who are, let's say, 8 or 9 years old. And while we have good experiences with this instrument, it is a brand new instrument. We published it only this year. So we have a lot of confidence in this, but we would like to see more studies, and we are studying it now with our colleagues here at the School of Dentistry. And so, yes, there is an OHIP school available. Yes, you can use it for adolescents. And yes, we would like to provide more data so that we have a little bit more empirical support above and beyond the very plausible idea that function, pain, appearance, and psychosocial impact are actually the cornerstones for an individual of any age. And so, yes, something is available, and we are doing currently research to support it even more.
Thank you. Yeah, and there was a specific question about OHIP school being used in Minnesota, and it sounds like in a exploratory research setting it is, but maybe more to come as those results emerge. I see a question from Mary. I don't know if you want to vocalize that, or I can read it.
Yeah, so I see here whether it has been used in Minnesota. Yes, the OHIP school is currently used in our School of Dentistry. So yes, that is in Minnesota, and yes, it is used.
But probably not quite yet broadly in the public schools, but maybe that would be the next step. So keep in touch with Dr. John if you'd like that opportunity to roll it out into the community. And Mary, thank you so much for your question. And I would say the series that MPHA has graciously sponsored to spotlight the work in oral health, whether it's in the clinical practice area or policy advocacy area, and today's session is on research. That is already so much support for spotlighting, raising awareness, but also moving the needle around population oral health. But I'd invite our panelists to potentially also answer that question specific to your areas of work.
Yeah, there's of course there's so much we can talk about with policy, and I think I'm gonna park that by itself. There's so much that I would love to say, and I'm sure CareQuest would love to say. But as far as like my research here, just to move a needle, you have to know where the needle is, and so that's why I'm particularly interested in measuring like who has it and at what level of scale. And so what can we promote? The adoption of diagnosis coding across the sector would be a great first step. Not that that's an easy step, but just being able to tell who has the disease in the clinical record, so that when we get to the point of being able to network records together, we'll be able to have better, a more standardized way of measuring the disease.
And Jen, I don't know if you want to comment on the work that we presented on at the American Public Health Association conference last November, and that was exactly around kind of who gets left out if you are only using the treatment codes and not able to assess the diagnostic codes, because as we know, there are folks who, for whatever reason, do not proceed with recommended treatments. So yeah, I don't know if you have a sentence or two about that, but just saying that we have looked into some of those questions.
Yeah, I guess in a nutshell, our presentation at APHA was like how you measure matters, and with method, we presented a couple measures in this webinar. Depending on which measure you use, you're going to get a different population. It might be older, or it might be like a different race or ethnicity makeup. And so I think it's worth studying what are the impacts of measuring different ways, and what sort of groups do you end up capturing with each method.
Thank you. And Dr. John, did you have any responses to that question about MPHA support?
Yeah, definitely. Because if you want to move the needle and you say oral health is an integral part of general health, and I guess we all would agree about this, then the next step is measuring oral health impact. And we would like to hear from you. We would like to partner with you so that we can integrate oral health with this very practical tool. Takes less than 2 minutes in basically as many settings as possible, because that has been traditionally quite a challenge. As pointed out by John, measuring caries and peritonitis with the physical measures is difficult. And therefore, many non-dental settings don't have dental measures included. And now, with a 5-item questionnaire that is psychometrically solid and clinically intuitive, I think there is an option to pragmatically include oral health. And we, of course, as oral health professionals, we wish that it would be implemented across the board, because it would allow that oral health is now integrated in medical settings and non-dental settings. And we would like to collaborate. We would like to give assistance because we think it is a great tool so that medicine and dentistry can actually come together with a very patient-centered approach.
Thank you. And I see Denny Vang had a question about research around place-based care. And I would say that's what Appletree's been doing for the past 4 decades. And so I invite you to connect. To put my email information here. And there's a QR code to the research collaborator page on our website that lists some of the efforts we've done to ascertain the impact of our community collaborative practice model, but we'd love to have additional collaborators to look into that with us. want to pass it back to Mary and thank her again for hosting us for this presentation today as she closes out with a few announcements. And thank you so much to both our panelists today.
I was going to say a big round of virtual applause. Thank you so much. This presentation was fantastic. And I know everyone who was here and who watches the recording will definitely learn a lot more about oral health and the public health connections with that. So we look forward to continuing the conversation. Just a couple quick notes. Our NPHA annual conference registration is open. Early bird rates are good until March 18th. And there's a lot of information that's being updated on our website. So please be sure to check out mpha.net, or you can scan this QR code. And we've got a lot of ways for you to stay involved with NPHA. We are a membership organization, so we absolutely encourage you to join, but you don't have to be a member to come to our events. We also have several awesome committees, health equity, policy and advocacy, membership and communications. So a lot of ways to get involved. And I highlighted a few of our upcoming events, webinars and in-person events as well. So thank you so much for your time today, and we look forward to seeing you again soon.